Good afternoon, everyone. Well, everyone who is on the Eastern Coast, it is 6 p.m. Eastern time. But we are going to start our second session for the Anato-Bee tutoring. We're all happy to see you all here. We have the Anato-Bee co-founders, myself, Dr. Haggerty, Drs. Peterson and Dr. Pesquera, our wonderful moderator, Dr. Frank. And then we also have Dr. Mapes joining us tonight. She hosted one of our regional host institutions, the West Institution, last year at the Pacific Northwestern University. So we're so happy to have her. We have amazing medical student tutors that are here with us as well. Before we get started, I just want to remind you all that we're all here focusing on the learning objectives that you can find on our website, and specifically the local learning objectives. So we're studying for the local exam, which will occur Saturday, January 25th. I know all of you have registered, but if you have anybody you know that may be interested in joining us, feel free to share them the registration link. I put it in the chat now. And the other thing that we have is we do have a survey that you can also complete. I'll put that in our chat. There's more information as well. It is optional, so do not feel obligated to take the survey, but we would greatly appreciate it if you did participate. Oh, it's not going to let me post it because it's too big. Let me see here. All right, there we go. So without further ado, I don't think I have any other other announcements, new announcements to make. But I'm going to hand it off to Dr. Frank so we can go ahead and get started. Go ahead, Dr. Frank.
Okay. Good evening, everyone. Our first session will be in anatomy. So Kyle Yang is a second-year medical student at Drexel University College of Medicine. He went to UCLA for undergraduate and majored in biochemistry. In his free time, he enjoys watching movies, playing games, and sleeping. He also enjoys traveling whenever he gets a long break from school. His specialty of interest is emergency medicine, but he is open to exploring other specialties as well. Without further ado, Kyle, you have the floor.
Hey, good evening, everybody. So excited to be here and to spend some time with you all. Let me just share my screen here and click the play button. Oops. All right. All right, so for my portion of the tutoring today, I will be doing anatomy and specifically skeletal structure. As Dr. Frank said, I am a second-year medical student at Drexel at the West Reading campus. Okay, without further ado, let's get started here. So the lecture objectives for today are taken right from the website, and specifically, like Dr. Haggerty said, they're the local objectives. So we have described the gross anatomy and characterizations of bone. Sorry, give me 1 second here so I can minimize this. Describe the gross anatomy and characterizations of bone, including descriptive terms for common bony landmarks. Identify the bones of the axial and appendicular skeleton. Define cartilage, how it differs from bone anatomically, and identify primary examples of cartilage in the human body. And finally, we want to define and classify the different types of joints. So starting right in order here, we have bone. So what is bone? I'm sure all of you know what bone is, but it is a hard, dense connective tissue. And when we think of bone, we're really thinking of these three main types of cells. We have that are responsible for maintenance and upkeep and sometimes the breaking down of bone. So we have osteoblasts, which are responsible for making new bone, and osteocytes, which are responsible for maintaining bone structure after bone has been formed. And then finally, osteoclasts, which are the main cells responsible for breaking down and reabsorbing bone should that be needed. And of course, we have the functions of bone here to support the body, to facilitate movement, to protect our internal organs because they're soft and squishy. They produce blood cells and they store and release minerals. Okay. Moving right along here, So how do we describe bones? So there are a lot of different types of bone in our body, and anatomists have come up with sort of a system of classification for bone. So just a few here, we have our long bones. So we're thinking about our femur here on the picture. It's longer than it is wide. We're thinking about short bones, which are equal in length, width, and thickness. And so on the picture, there are some examples of some of the bones in your foot that would be classified as short bones. We have flat bones, which are thin and curved. Specifically, as an example here, we have our sternum, which is, for the most part, flat and curved. We have irregular bones, which are not easily defined and complex, and the example given here is our vertebrae. You can see it is very oddly shaped. It doesn't really fit into any of the previous categories we mentioned before. And so we just call it an irregular bone. And then finally, we have our sesamoid bones. And the important one here is mainly your patella or your knee bone. Okay. And so moving on from the types of bones, anatomists have also come up with a system to describe bony landmarks. And these make it easier for, medical students, doctors, anatomists to sort of describe what part of the bone we're talking about. So we have our tuberosity versus our tubercle. It's usually a rough surface here where you have attachment of ligaments. So in the blue box in the middle here, tuberosity, and then also a tubercle at the end. So we have our sulcus, which is a groove in the bone, and it is outlined in the green box over here. Finally, we have foramen and fossa. So foramen is like a hole in the bone. So foramen over here is on the skull down at the bottom right of the screen. And we have a lot of those, particularly in our skull. So we have our head, which is a rounded surface on the bone, and it is outlined in red up at the top with our the head of our femur, which sort of attaches to your hip. And then finally, you have your diaphysis, which is your long part of the bone, or you can think of it as the shaft. So just going through with the femur example here, the shaft would be the middle part, and it's long. And then finally, you have your epiphysis. I can never pronounce that correctly, but it is sort of the end of your long bone here. And again, with the femur, you can see the end of the bone or sort of at the tops and at the bottoms. Okay.
Kyle, it's Dr. Peterson. Are you able to use your cursor?
I don't think so. I can't see my cursor when I'm presenting.
Okay. Okay. Did you want maybe Dr. Frank to jump in and while you're narrating to move the cursor as you're doing that?
Sure, that would be amazing.
Okay, and then the second thing, maybe before we move from this slide, why don't you explain the difference between a foramen, which you've already defined, and how that's different from a fossa, because it is in a box there on your slide.
I kind of have to defer to you on this one, Dr. Peterson. I actually don't quite remember the difference here.
And that's fine. So again, Kyle mentioned that a foramen is a hole through a bone. They can be big or small. A fossa is a shallow depression in a bone. And so you're seeing a fossa, and maybe Dr. Frank could show you that shallow depression in the ilium of the pelvis.
I'm not sure that I have. Can you see my cursor? Because I don't think you can.
No.
Because I'd have to take over the
Dr.
PowerPoint.
Frank, if you go to annotate, and then you can select arrow. See how it's highlighting when I click?
Where is this at?
Annotate, it's the bottom, at least on mine, it's the bottom left of my. There's a little pencil.
Yes, okay.
If you click that, you can click the arrow, or you can, I haven't tried the mouse function, but can you see my mouse, everyone? No?
Okay,
Yeah.
so
And for those of you that are watching, thank you for your patience.
Yes.
I think this will just be very helpful if we can actually point different objects out and structures out to you.
Yeah.
I'm not sure
Uh,
what's going on here. Annotate.
yeah. Kyle, can you share your screen again, please?
Oh, yep, sorry. Just to stop at some point. Here we go. There you go.
Yay.
Does that work?
So Dr. Frank, did you find the annotate?
Yes, can you see the arrow now?
Did you click on the screen? There you go. Now we see it.
And Kyle, I thought I saw your cursor moving around, or was that you, Dr. Haggerty?
Oh, that was probably me. So you
Okay.
can also, Dr. Frank, if you click annotate at the very, very top, it says mouse.
Yes.
Click that.
Okay, I did.
And let's see if we can see your mouse. Don't try moving it around.
I am.
Okay. So maybe the arrows is going to be our best bet, and for the time's sake, I would just go back, click annotate, click the arrow, and then as Kyle is going through and annotating, you can point things out if you are okay with that.
All right. So do you see my arrow there?
I
Is
do.
that-
Yes.
And we did in the chat, somebody asked tuberosities versus tubercles. Kyle, would you like to give it a shot?
Still a little confused for that one myself too.
I always think of them, and Dr. Peterson, correct me if I'm wrong, I believe tuberosity is larger, but they're both pretty much the same, essentially. So all these projections, like a tuberosity versus a tubercle, a process, they're enlarged areas on the bone. They're where muscles attach. So where they interact, it's going to create this like bulge or protrusion of the bone, which we call a tuberosity or a tubercle. Again, I think tubercle may be larger from the two, from what I can recall.
I think you said it correctly the first time. Tuberosity, Dr. Haggerty, is usually larger than, and
Tuberosity.
tubercle smaller than.
Tubercle. Okay.
So thanks for the question in the chat.
Yeah,
We
thank
appreciate
you.
that.
Yes.
Any other questions before we move on from this slide? As Dr. Peterson also said, the difference between foramen and fossa, whereas foramen is a straight hole through the bone, like you can stick your finger or something small and it'll pass through, versus a fossa, which is just a depression, so it doesn't actually go all the way through the bone. You would not be able to sort of take a pin and poke it through to the other side. Okay. If no other questions on this slide, we'll continue on here. Okay. So just as our quick check number one, and sort of this one doesn't have multiple choice, so if you could all just answer what you think in the chat. So how would you classify the bone labeled with the green arrow and versus the bone labeled with the red arrow? Are they long bones, short bones, irregular bones? Just take your best shot. We'll give it maybe 30 seconds and we'll just move on. Okay. Everybody give their answer. We're all good. So, still see some answers coming in. Okay, perfect. All right. So at this point, we're just gonna move on here. How would we classify the bone? So the one in the green arrow, I would call it a long bone. And this, I wanted to bring this up as an example, because when we think of long bones, we generally think of like a massive bone, such as the femur. But when we're talking about long bones, it's really descriptive of the general shape and not the overall size. And so a smaller bone, such as the ones in your finger, can also be considered a long bone. And then finally, we have the red arrows, which would be a short bone. You know, it's more or less equal in length with, it's like a little box. And so that bone in the bottom of your hand would be considered a short bone. Okay. Moving right along here. So on to our next topic here, we want to talk about cartilage. And sort of this is your soft, cushiony connective tissue. There's no calcification, so it is not as a solid or as sturdy as bone. It is made from cells called chondroblasts. And for our examples here, we have your ear, your nose, and then between your joints and vertebrae. And Dr. Frank, if you could point to the picture at the top here with the ear and the knee bone. Really, there are three different types of cartilage here. There are your hyaline cartilage, your elastic cartilage, and finally your fibrocartilage. So your hyaline cartilage, it sort of covers your articulate surfaces of your bone. It's smooth and it sort of helps joints move more smoothly. And the example shown here is sort of at your knee. There's cartilage that covers the two bones that connect at your knee joint, and they help to move that joint smoothly. You have your elastic cartilage, which is very flexible. It still provides some structure, but it's flexible. And here you're thinking about the cartilage of your ear. You can move your ear. It's flexible and it sort of provides that support needed. And finally, you have your fibrocartilage. It's tough. It's made of thick fibers. This is probably your strongest of the cartilage, but it's your least flexible. And one of the classic examples we tend to point to is the intravertebral discs in between your vertebral bodies at the bottom here. Okay, and moving right along here from cartilage, we have our next topic, which we are discussing your axial versus your appendicular skeleton. And so when we think about the human skeleton, it's really broken up into these two main, very generalized categories. I like to think of the axial skeleton as sort of everything in the middle. So we're thinking your skull, your rib cage, your vertebrae, your sternum. These are all parts of your axial skeleton. And then your second broad general categorization is your appendicular skeleton. And I like to think of it as like your appendages, right? So it would be the bones that make up your arms, your legs, and your shoulder as well. And then also your pelvic girdle. Moving right along here. So focusing in on the axial skeleton a little bit more, we want to talk about specifically the skull. And the skull is made up of many different bones that are fused together. So we have your frontal bone, and it's all labeled here. We have your frontal bone, as Dr. Frank is pointing to, your parietal bone, which is behind that, your occipital bone, your temporal bone, your maxillary bone, your mandible, sort of your lower jaw, and then your zygomatic and nasal bones. And I put the stars there to indicate that you don't need to know your zygomatic or nasal bones for your local objectives as of right now, but I believe the other ones you should be familiar with. Okay, moving along from your axial skeleton, the second part of your axial skeleton, the main part is your vertebrae or your backbone, and your vertebrae is made up of many different parts, and we classify them based off of where they are on your spine. So we have your cervical portion, which is at the top, and it goes C1 to C7. You have your thoracic portion, which has 12 thoracic vertebrae. You have your lumbar portion, which is sort of your lower back area. So we have L1 through L5. And then we have your sacrum and coccygeal, which are your sort of your tailbones and the parts of the bone that you sit at. And a very useful mnemonic that we were taught and that we use all the time is breakfast at 7, lunch at 12, dinner at 5. And that really shows you how many vertebrae are in each of those different classifications. So we have 7 cervical vertebrae, 12 thoracic vertebrae, and 5 lumbar vertebrae. Okay. Moving right along, now we want to discuss a little bit of our appendicular skeleton. And again, like I said, whenever I think of appendicular skeleton, I think of appendages. So these are the bones of your legs and your arms. So we have your clavicle, which is your collarbone, and your scapula, which is sort of your shoulder bone. And then in the upper extremity, we have all of these different bones, which are labeled on the image to the right here. We have your humerus, your ulna, your radius, your carpals, your metacarpals, your phalanges. And those are sort of the main bones of your arm here. Okay, thank you, Dr. Frank. Okay, and then so that was your upper appendage. Now let's move on to your lower appendage, your legs. So part of the appendicular skeleton is your os coxa, or your pelvic bones and your pelvic girdle, and it's really made up of three separate parts we call, and they're called the ischium, the ilium, and the pubis, and you can see them labeled here. It's really one big bone, but the three separate parts of it, they're what make up the one big bone. And then, so moving right along, we have our lower extremity bones. So our femur, our patella, our knee bone, our tibia, our fibula, our tarsals, and our metatarsals, which are the smaller bones in your foot. Okay, so time for quick check 2. This one I think is a little bit more conducive to multiple choice. So Dr. Piscura, if you could put up a poll. So are ribs part of your appendicular axial skeleton? Let's say A is appendicular and B is axial. Okay, perfect. And if Dr. Piscura, you could end the poll. We have a majority, about 71%, choosing answer B, which is your axial skeleton here. And you would be correct. It would be your axial skeleton, because, like I said, it's sort of in the main part of your body. It doesn't really fit into any of your appendages. It's not part of your arms or your legs. So yes, we would classify this as part of your axial skeleton. Very good job for all of you. And then finally, I wanted to move on to the different types of joints that we see in your body. This is just a quick overview of the 3 different types of joints we have in our body. We have your fibrous, which is found sort of in the sutures of your skull, which is the area where all of those different skull bones have fused together to form your skull. You have your cartilaginous joint, which is found at areas where your ribs attach to your sternum. That's more so cartilage. And then finally, you have your synovial joint, which is more present in the freely movable joints of your body. Okay, so just moving on, let's start with fibrous joint. So we have our fibrous joint, which is bones connected by a dense fibrous tissue. And as I mentioned, the major examples are your skull, especially with the sutures where the different bones of your skull have fused together. And finally, in between your ulna and your radius, which connects them, and we call that a syndesmosis. Okay. Next, we have our cartilaginous joint, which are bones connected by cartilage. These are sort of movable, but not really. So an example here, we have your pubic symphysis, which is the cartilaginous joint, which connects the 2 different bones of your hip, the major hip bones. And then finally, like I mentioned, we have our rib cage, which is where our ribs connect with our sternum. That area highlighted in blue, that's all cartilaginous joint here. Okay. And then finally, moving on, we have our synovial joint. Now, this is the one that's freely movable. This is really the one you think of, or I think of, when I think about the classic joints in, like, at my elbow or at my knee, or at my ankle. They're really freely movable. There are a lot of different types of joints based off of how they move. For your local objectives, we want you to be able to identify and describe your hinge joint here. And the example of a hinge joint is really at your elbow. We have your ball and socket joint, and the classic example I think of when I think of a ball and socket joint is your hip joint. And then finally, you have your plane joints, which is between your tarsal bones of your feet. And these bones, this joint has both bone surfaces encased by a synovial membrane and then reinforced with ligaments. Okay. And then finally, we have our references. And I think that is the end of my portion. Are there any questions that anyone has for me or Dr. Peterson, Dr. Frank, Dr. Haggerty?
Kyle, if you would, why don't we go back to the upper extremity slide? Let's just point out, because I think it's really important that the students have a way to distinguish the radius from the ulna. That gets kind of tricky. And then we'll do the same thing, helping them distinguish the fibula from the tibia, which is not quite as tricky. But again, if Dr. Frank could highlight that the radius is always going to be on the thumb side of the hand. And if you could point out or at least describe how to distinguish the thumb from the other digits, Kyle, based on the number of phalanges, I think they would find that helpful as well.
So your thumb, right, it isn't as long as the rest of your hand, so it just has less phalanges. I don't remember if it was 2 or 3, Dr. Peterson. So you're 2, and then the rest of your fingers have really 3 phalanges. So if you're really in doubt, looking at a donor, you can sort of see if you can tease out the phalanges and try to count them. And again, your thumb is usually sort of your shortest of all your fingers, so that's the one that I really look for to orient myself. And as Dr. Peterson said, so your radius is always going to be the bone that's closest to your thumb, whereas your ulna is going to be on the other side.
We could go to the lower extremity slide. Let's just help them distinguish tibia from fibula, first of all, just by, size, the diameter, and then again, the fact that your fibula is not weight-bearing and is always the more lateral of the two.
We also had a question of what makes the ankle bones in the chat.
Ooh, the ankle bones. Oh man, it's been a while since.
So Kyle, again, I think you already said this in your slides. The wrist bones are carpal bones, and then the ankle bones are the tarsal bones. And they're very, very similar to each other in the fact that some are considered to be short bones. So they're just, as long as they are wide as they are thick, but some of them have very irregular shapes as well. And that's where it gets kind of tricky. And we wouldn't ask that just for all of you that are tuning in today or watching this later on. We're not going to make you distinguish in the wrist or the ankle bones the difference between the short bones and which ones are irregular. So that was a great question, though.
Yeah, and more if you're thinking about when you bend down and you palpate the sides of your ankle, those things protruding out, those are your malleoli, and there's one on the fibula and one on the tibia. But yeah, and that is getting into nitty gritty. That's, a lot of these processes and grooves, they're all named many things, and we are not requiring you to know those many things. So.
Okay. And then just going back to what Dr. Peterson was talking about, the tibia and the fibula. So your tibia is big. It's bigger in comparison to your fibula, and like she said, it's not weight bearing. And so if ever you're looking at the lower extremity and you're trying to decide, again, your tibia is the one closest to your big toe, and your fibula is more lateral to it, and your tibia is usually the bigger one, the one that looks more sturdy, because that's the one that really bears the weight of your body, and less so of the fibula.
I'm just saying a question in the chat that came in from Emily. Is the fibrous joint easier or harder to move? So fibrous joints over time become calcified, so suture lines. So you should not have movement between the bones in your skull, but there is some movement as we grow from an infant to puberty. There is some movement because the brain is growing and it needs room to expand. Just a thought though, Sam, I appreciate that you chimed in there and you did a great job, but we'll try to answer as best we can. The faculty will try to answer the questions in the chat, either out loud or typing in an answer, just so that we're sure that the information that's getting recorded is really accurate. All right, Kyle, thank you so much.
Of course. Thank you so much for listening, everyone, and giving me a chance to be here and share some of the knowledge we've been learning.
Okay. Thank you, Kyle. Our next section is histology, and our presenter is Hailey Long. And is Hailey with us now?
Yes, sir.
Okay, great. So Hailey is from Madison, Alabama, and graduated from the University of Mississippi in 2023 with a BS in Biological Science and a BA in Psychology. She is currently a second-year medical student at Edward Via College of Osteopathic Medicine in Auburn. When not studying, Hailey loves reading and spending time with her sweet cat, Bobbin. Maybe Bobbin will make an appearance tonight. Be nice. Hailey's favorite part of anatomy is musculoskeletal anatomy. So, Hailey, I hand this over to you.
Thank you very much for that introduction. I'm just going to pull up our PowerPoint for today here. Okay. Okay. Today, my presentation is going to be on histology for cartilage and bone. I would like to acknowledge that this presentation is adapted from a presentation put together by Mackenzie M. Blackstock, a now OMS 3 student. Here are our learning objectives for today. First, we're going to talk about the microscopic structure and molecular composition of our 3 types of cartilage: hyaline, elastic, and fibrocartilage, and correlate those types with their locations and functions. Then we're going to look at our 3 types of bone cells: our osteoblasts, osteocytes, and osteoclasts, and describe their morphology, function, and locations. And then we're going to look at histological structures and compact or cortical and spongy or trabecular bone. So at our previous session, we talked about different types of connective tissues and how there are different categories
Hailey,
of connective
I'm
tissue.
sorry. I'm so sorry to interrupt
Yes, ma'am.
you. Can you use your cursor so that Dr. Frank does not have to worry about indicating multiple things on everyone's slides? Is your cursor available? Do you know?
Can you see my cursor on the screen?
Can you move it? Yeah, I can see it. All right.
Okay.
Just
You
to
just
get
want
you
me
off
to-
the hook, Dr. Frank, I thought you were doing an amazing job, but I didn't want you to feel like you had to. We had that in the
Yes,
it wasn't available in the last presentation.
okay.
Just remember to indicate as you're going through, and you're doing a great job. So I apologize for
Okay.
interrupting.
No, thank you for the reminder. Thank you very much. Okay. So we're going to talk about these different categories of connective tissue. And I think last week we talked more specifically about connective tissue proper, which has 3 different types: loose, dense irregular, and dense regular. But this week we're going to get into what's called supportive connective tissue, which includes cartilage and bone, as well as some other tissues. Let's try and make sure I have this cursor going correctly for you guys. I wonder if I can do a laser point. Oh, okay. Does that show up for everyone? And if anyone can confirm that. This laser point? Great,
Yeah,
thank you very
it's
much.
much better. Yeah, thank you.
Great. Okay, because my cursor was disappearing. Okay, so as another little review, here's just our 4 types of tissue in our body. And then here we're going to be focusing on this connective tissue. So as we said, there are 3 broad categories of connective tissue. We have our connective tissue proper, our supportive connective tissue, and our fluid connective tissue. So our connective tissues have 2 major components. We have our cells and our extracellular matrix, sometimes shortened to ECM. And extracellular matrix includes both ground substance and then fibers that make up that extracellular matrix. And our supportive connective tissue can then be broken down into 2 forms. We have our cartilage, and then we have bone. Cartilage and bone. So cartilage is what we're going to talk about first. Our cartilage is composed of cells called chondroblasts, which are found primarily within the perichondrium. And then we also have chondrocytes, which are found within spaces called lacunae. Then we have our extracellular matrix component. The fibers there are specifically called collagen. And then our ground substance is made up of proteoglycans. Now, cartilage is interesting in that it's avascular, meaning that it does not have any blood cells in it. And so this means that all of our nutrients have to diffuse from our blood vessels through the extracellular matrix to then reach those chondrocytes. And another thing to add here is that because the nutrients have to diffuse and cartilage is avascular, this means it's much more difficult for cartilage to heal after an injury. So that it can be very difficult for cartilage to heal. Now, this image here is going to show our 3 different types of cartilage. We have hyaline cartilage, fibrocartilage, and elastic. This first image is pointing to our hyaline cartilage. Then we have fibrocartilage in our second part of our image, and then elastic cartilage at the bottom. Elastic cartilage, which we'll talk about more later, is unique from our other 2 types of cartilage in that there are these elastic fibers in the matrix, and you can really see that here in our image. Next, we're going to talk about hyaline cartilage. Specifically, characteristics for hyaline cartilage, it's our most common type of cartilage in the body. Most common. And it's also very strong and flexible, which would make sense why it's our most common type, because that's very useful throughout the body. And it's described as having this smooth surface, and it's referred to often as glassy. Microscopically, hyaline cartilage has short and dispersed collagen fibers with lots of proteoglycans. This is an image of hyaline cartilage on our right at 50 times magnification. And in our lower image, it's that same image, just now more illustrated, and then with the specific parts of the cartilage pointed out to us. So here we have our chondrocytes, these more smaller like fish eye looking things, and then it's surrounded by perichondrium. Hyaline cartilage is found in specifically our rib cage, our nose, trachea, and the end of bones where they meet to form movable joints, as well as our growth plate and the embryonic skeleton. So these are all different places where hyaline cartilage is found. All these places need to be strong, but also flexible. These are more images of our hyaline cartilage. And it's that same image on the previous slide, but now we are at 100 times magnification here on our left and 200 times magnification here on our right. In this image on the left, you can see the chondroblast. That's what this box is around, pointing to these cells here in this chondrogenic layer. And then we have our chondrocytes here further down, and these are larger cells. At 200 times magnification, we can see our chondrocytes within the lacunae, which are just these spaces within this tissue itself. And then once again, those chondroblasts. Next, we're going to talk about our fibrocartilage. Fibrocartilage is our strongest type of cartilage, and it's very tough and can withstand compression and shear forces, which would make sense because if you need to withstand some significant forces, you would want that cartilage to be very strong, very tough. Microscopically, fibrocartilage has thick bundles of collagen fibers dispersed throughout our matrix. And that's what we can see here in our image on the right, which is a fibrocartilage at 100 times magnification. We can once again see some chondrocytes within the lacunae. But this is different than our hyaline cartilage because these are in thicker bundles. Fibrocartilage is found specifically in your meniscus of your knee, the intervertebral disc, and your spinal column. These are the discs found between each of your vertebrae or your bony parts of your spine. Then we also find this in our pubic symphysis, which is between your what are they called? Your hip bones. There we go. Where the two sides meet each other in between, like where my thumbs would be, is your pubic symphysis, which is fibrocartilage. Also in your sacroiliac joint, which is where your sacrum meets your hip bone as well. And those are our places where fibrocartilage is found. Next, we're going to talk about elastic cartilage. Elastic cartilage, as we talked about a little bit earlier, contains both elastic fibers and collagen. So both of these two types of fibers. And elastic cartilage provides both rigid support as well as elasticity, as it is in the name. So this type of cartilage can return to its normal position when it moves, which can be really beneficial for certain parts of your body, as we'll talk about in our examples of where this is found. Elastic cartilage also can really only be differentiated from hyaline cartilage when it is stained properly so that you can see those elastic fibers. Now, microscopically, as we've mentioned, elastic cartilage contains many different elastic fibers, and our chondrocytes in elastic cartilage also tend to be flatter in appearance. And let's look at that in our image here. Is that 200 times magnification, and here in our labeled image, we can see our chondroblast, which are our little fish eye structures, and they're smaller, to clarify, than our chondrocytes, which are our mature cartilage cells. And these chondrocytes are within our lacunae. Okay, where is elastic cartilage found? Well, it's found in your external ear, your auditory canal, which is also involved with your ear and hearing, and also your external auditory meatus, which is another thing that's associated with your ear. That's a specific structure associated more with your skull as well as in your epiglottis, which is found at the back of your throat. And as we said, all of these structures are able to return to a normal position when they're moved. So like your ear, and you can stretch it out, but it returns back to its normal structure after you let it go, essentially. Here are some more images of elastic cartilage. I think, yes, on our previous slide, it was at 200 magnification. This is a more zoomed out view at just 50 times magnification. And it's harder to see some of the structures we were talking about in this image. So that's why it's more important for elastic cartilage to look at this close up view. But there's nothing else new in this slide besides that 50 times magnification. Now we're going to launch our first poll to see how we're doing with our comprehension of this material. Our first question is going to be, choose the option that correctly matches the cartilage type and location. We have A, fibrocartilage, external ear, B, hyaline cartilage for the growth plate, and C, elastic cartilage, the nose. And if you guys could just select that answer.
All right, I'm going to close the poll in 5, 4, 3, 2, 1.
Thank you very much. Now okay, there we go. Okay, so most of you answered B, which is our correct answer, hyaline cartilage. One of the examples of that is your growth plates, and our cat has joined us. Your nose is an example of hyaline cartilage, and your external ear is an example of elastic cartilage. And if I said one of those wrong, please correct me. Okay, our second poll question is, what is the type of cartilage shown in this image? Is it A, hyaline cartilage, B, fibrocartilage, or C, elastic cartilage?
All right, we are going to go ahead and close the poll in 5, 4, 3, 2, 1.
Thank you again, Dr. Caspira. Okay, so this is a bit of a mixed run, and that is perfectly okay because you've seen these images one time. The correct answer here is hyaline cartilage. I chose to emphasize hyaline cartilage because it is our most common type in the body. And microscopically, let's just go back to that hyaline cartilage slide for a few seconds. There we go. Hyaline cartilage has really short and dispersed collagen fibers with a lot of proteoglycans. And this, I believe it's this image that was the quiz question or poll question. And here we can see the shape is a lot different than the other ones, but that might just take some familiarity with looking at these images and other examples to really understand that. And
It's Dr. Peterson. Can I just jump in really
yes,
quickly?
ma'am, please.
Yes. So with hyaline cartilage, what some of you might notice is that there seems to be small clusters or groups of those cells within the lacunae, and they have a special name, and that's not important. But when you see clusters of cells, and around those clusters of cells in cartilage, where it's staining a darker color, that is really indicative that you are looking at hyaline cartilage. And then if we go maybe, I think it's a couple of slides ahead, Hailey, let's look at the elastic cartilage in comparison. And so what you'll see here is that there are still many cells, but they're not so clustered. And what you can see is rather than just dark staining areas, you see fibers. So the fibers are actually very noticeable when we use a special stain that will make those elastic fibers show up more clearly. So I think that's a good way to think about how am I going to differentiate elastic from hyaline. But you're doing great. You're doing great.
Thank you so much,
Yeah.
Dr. Peterson. I know that histology is honestly like differentiating from images is not my strong suit. It gets better with time though, I will say. Okay, our next thing we're going to discuss is bone. So bone is our hardest connective tissue, and it has several important functions that I want to just go over really quick. First, bone helps to support the body. Obviously, we have our skeleton, and without bones, we would not be able to move, which is our next function, because the bone facilitates our movement in a good relationship with our muscles, which help to move our bones. Bone also protects our internal organs. If we think about our rib cage is protecting our much softer lungs and hearts that are encased within our ribs. Bone also produces blood cells, and that is a process we call hematopoiesis, which is a word on one of our slides that we'll try to at least expose you to in this presentation. Bone also stores and releases different minerals and fat. Bone also contains a rigid extracellular matrix that is composed of collagen fibers as well as a mineralized ground substance. And this just means that once the bone secretes its ground substance, if the cells within bone secrete that substance, then just hardens, and that's what allows bone to be a hard tissue. And one thing that was emphasized a lot to me in anatomy is that bone is a living tissue. It is very highly vascularized. So unlike cartilage, bone can heal more rapidly when it is injured, and that is what allows you, if you break a bone, to not have a broken bone for the rest of your life, hopefully. And bone is also constantly remodeling, and that's the job of several of the bone cells we're going to talk about, where we add more bone and we also take away bone. And part of that is in relation to this function to store and release minerals. Okay, and here's just a general image of one of the long bones in your body, our femur. And I'm not sure if I wanted to point out anything specific to you in this image, but a lot of these terms here are not in your learning objectives, so I would not worry about them this exact moment. The only things that are important here, I believe, is this compact bone, which is here on the outside of this long bone, and then you have spongy bone, which is more on the inside. And those are the two types of bones that we're going to talk about very soon. Okay, now we're going to get to a kind of crowded slide, the types of bone cells. Actually, the next slide. The bone cells are what are crucial to our function of bone. And we have 3 types that are within your learning objectives. And just for a little bit of completion, I added a 4th type in as well. So osteogenic cells are our first type. And these are not in your learning objectives, but it's, as we see in this image here, a stem cell essentially for our bones. Then our next type, we have osteoblast. Then we have osteocytes. And then we have osteoblast with a C. And as we said, osteogenic cells are not in your learning objectives, but we're going to just go over it really quick. So osteogenic cells are the only bone cells that can undergo mitosis, so splitting, one cell splitting into 2 daughter cells and dividing. And so these osteogenic cells are what are responsible for replenishing old bone cells once they are ready to be renewed. And they can differentiate our osteogenic cells and then develop into cells called osteoblasts. Osteogenic cells are located in the deep layers of the periosteum and the bone marrow. Once again, not in your learning objectives. Now, osteoblasts are the bone cells that are responsible for forming new bone. And I think before in other classes I've had, we've said osteoblast, the B here is for building. So for building bone, osteoblast, build bone. They create and secrete this collagen matrix and calcium salts. And then they are located within the growing portions of bones, including just beneath the periosteum and endosteum. These are just different places that we can see in some of our images and our histology. Now, our osteoblasts, which are shown here in this image, a little cartoon version, they can develop into osteocytes. Now, osteocytes are just osteoblasts that have become surrounded by a calcified matrix, trapping the cell in bone and triggering a then change in the structure of the cell itself. Osteocytes are the primary cell of our mature bone and the most common bone cell that we have, which makes sense because not all of our bone can constantly be building. So we have this just kind of trapped cell making up most of our bone in our body. Osteocytes are located in the matrix in the space called the lacuna. And here's just a little cartoon of an osteocyte. And our last type of bone cell is called an osteoclast, which are responsible for bone reabsorption or breakdown. Osteoclast actually originate from white blood cells, not our osteogenic cells that we talked about on the previous slide. And these osteoclasts are located on bone surfaces, as well as at sites of old, injured, or unnecessary bone. And they have this kind of interesting structure and form that we can see in this image, and we're going to look at that a little further as well. But in comparison to our other images, they look a little bit different. And here are some images of some bone cells. This one on the bottom just appears to be a bit more zoomed in than the one on the top. So here we have some osteoblasts circled here at the top, and these cells look smaller with one prominent dark nucleus in the center. And then we have an osteoclast, which, as we said, is our cell responsible for bone reabsorption. And as we saw in that previous cartoon-ish image, these look a little funkier. They're a larger cell than our normal osteoblast, and they have more dark nuclei inside of them than just one, as we see with the osteoblast. Then we can see some osteocytes, and these are found within the lacunae. Those actually there. And this is just another osteoclast, a more up close image. As you can see, much larger than our other osteocytes or osteoblasts. Okay, now it's time for our second round poll questions. And I really appreciate all of your participation tonight. Okay, first question. What type of bone cell is trapped in a calcified matrix within lacuna? A, an osteoblast, B, an osteocyte, C, an osteogenic cell, or D, osteoclast?
Right, and I'm gonna close the poll in 5, 4, 3, 2, 1. You taught this really well, Haley. They really did great.
Oh, there we go. Okay. B, osteocyte is our most common response. Let's see. That is the correct answer. So yes, our osteocyte, our bone cell, our most common cell, is in fact trapped within a calcified matrix. Okay, our second poll question is, what cell type are the arrows pointing to? Do the arrows show up? That's a good question. Yes, okay. A, osteoblast, B, osteocyte, C, osteogenic cells, or D, osteoclast?
All right, and I'll close the poll in 5, 4, 3, 2, 1. There we go.
Okay, most common answer was D, and D is in fact our correct answer. Our osteoclast are our funky looking cells. They are much larger than our other bone cells. And that is in fact what our arrows are pointing to. We can see just the size difference between this cell next to it, probably in osteocyte or blast, and in comparison to this osteoclast. Okay. Now let's talk about some types of bone. Compact bone is stronger than spongy bone and also dense enough to withstand compressive force. So it's strong and it's dense. That's what we need to think of when we see compact bone. Compact bone provides both support and protection, and it's located beneath the periosteum in the diaphyses of long bones. And here are some lovely images of compact bone. So within this box here, you can just see almost like layers here of different layers of bone, and they are just very tightly compressed together. And that's just what we think of when we think of compact bone, as the name implies. In these two images. Now, the structural unit of compact bone is called an osteon or Haversian system. And we have what's called lamella, which are layers of concentric rings of calcified matrix. And as we can see in our images, those definitely look kind of ring shaped, very circular or oblong, however you want to say it. Those are our lamella. And then we have a central or Haversian canal, which runs down the center of each osteon and contains the blood vessels, nerves, and lymphatic vessels. And this would be our central canal here and here and this image as well. Now, compact in comparison to spongy bone, we have these two images, more cartoonish here. So this entire structure here is our osteon, as we were discussing, with these lamella that are the concentric rings, and in the middle there with the our perversion canal. And this box here is showing all of those blood vessels and our nerves and lymph vessels running together within that canal. Now, our spongy bone is a bit different. I'm not sure what happened to our slide about spongy bone. Interesting. Okay. But spongy bone, as we can see here at the end of our long bone, the femur, is not in these dense concentric rings. Instead, we have these canaliculi. That's this word here on the slide. And they are just kind of more arranged a bit more haphazardly, these canaliculi. And we also have what are called trabeculae. And here is a more cartoonish image of our spongy bone. And just structurally, the spongy bone does look a lot different than our compact bone. And the spongy bone is where our bone marrow is found. And this is where our bone marrow produces the red blood cells and white blood cells. If any of the professors want to add anything, I would very much appreciate it.
Hailey, if you went back a couple of slides, you had an actual photo micrograph of the trabeculae in spongy bone. So maybe, yes. So
This
if
one?
No, the one where, keep going, I'm sorry, right there.
There, okay.
So
Right.
so they can get a sense of the trabeculae, and they can see that they're more tentacle-like. I think on another slide you had an image similar to this, but it was a little bit more zoomed out.
Let's go back. Okay, yes,
Perfect.
here. This is some good spongy bone. Right,
That's perfect.
okay. I think a slide somehow got moved or deleted or something, so I do apologize for that. And if we have any questions about spongy bone, we would love to answer that. We were at the end of my presentation there as well. Here are references. I think we have a question.
Yes, Juan, can you unmute and ask your question?
Yeah, what's the structural unit for spongy bone again?
Yes, I'm gonna stop sharing my screen for a second and see if I can find my original slide for spongy bone. Oh, goodness.
So, Joanne, I'll jump on. So the structural unit is really, because they're tentacle-like, so hopefully you can see like my index finger. So you have it, and I was gonna maybe ask Hailey to give these definitions to all of you. You have a really thin membrane that wraps around, for instance, my index finger, and that is the endosteum. And so that's a highly vascularized membrane, which allows these rapidly growing osteoblasts to lay down now not concentric rings, but layers. So the trabeculae can kind of grow more in the horizontal plane. So they increase the number of calcified matrix. And that's the lamellae that we talk about within the trabeculae. I'm hoping that that helps you better understand that.
Yeah, thank you.
Yes. And then Hailey, maybe you could just give them a brief definition again, how the periosteum differs from the endosteum, And then the root word, I'll just jump in right now. The prefix peri means in Latin surrounding. So if you have a perichondrium, it's a membrane surrounding cartilage. If you have a periosteum, it's a membrane that's surrounding bone. And I think Hailey used both of those terms. And then do you just want to give them again a sense of the difference in location of the periosteum from the endosteum? I think that would be helpful.
Yes, ma'am. And I did find the spongy bone slide, so I do apologize for that. It somehow got moved to a different part of our presentation, but I just wanted to make sure this was in our recording for later and for future students to see as well. And then let's go and find our slide with our picture of the bone, our long bone, to talk more about the periosteum versus our endosteum. That was in this image.
Maybe even that final cartoon slide would be helpful because they can see a little bit closer image or cartoon.
Yes. Okay. Let's see. Yeah, there's part of it here, our periosteum. And then endosteum is here. But periosteum, as Dr. Peterson mentioned, is this more outside portion of our bone. As she said, perium means surrounding, and I like to think of our perimeter. So like that same root is in perimeter as in periosteum and perichondrium. So it's this outside portion, while endosteum is more an inside portion. And let's go find this other image as well. Sorry, that's horrible to look at as that's zooming through. And then here on this compact bone side, laser pointer's gone. Okay, we have our periosteum, another close-up image of it where you can more see what it's doing. But it has layers of its in of itself, but it is just this more outer layer of our bone. So here we can see that it's surrounding our different layers of bone. And then our endosteum, let's see if it's on here. We can see it on this part of the image, and it's not the clearest what it's pointing to in this image, but think of the inside portion. So periosteum surrounding endosteum, more interior to the bone. And if anyone has anything else they want to add to that, I would very much appreciate that.
I'm just going to say that the periosteum and the endosteum are made by a different kind of cell that you actually talked about previously, Hailey. Those are fibroblasts. So this is a type of fibrous connective tissue. And so we would expect to see sort of thin, flat, spindle-shaped cells on the tentacle over on the right-hand side, the trabeculae. They would be laying down that thin fibrous membrane covering the surface of those trabeculae. And the same is true for the periosteum. At least the outermost layer, again, is a fibrous connective tissue layer made not by any kind of bone-producing cells, but made by fibroblasts. So I think you did a really good job of helping the students appreciate that. So thank you.
Hailey, two questions. While you're on this slide, can you show the central canal and what runs through it?
Of course. So on this left-hand side, we can see the central canal. And in this image, it's taken up by these 4 different vessels. That's what they appear to be on the side. And within that central canal, we have the side view helps to clarify it a bit more, but we have our blood vessels, an artery and a vein, as well as a lymphatic vessel transporting lymph. That's that little greenish shade that this arrow is pointing to. And then we have a nerve shown here in yellow. And so that's just our what we call a neurovascular bundle. that runs through each of our concentric rings here of our conversions. So.
And the last thing I would ask is, can you explain the difference between osteoblast and osteoclast again, just briefly?
Of course. So, an osteoblast, we hear that B sound, B, bone, building. That's what I want to think of. Osteoblast is for building bone. Now, osteoclast, I'm trying to think if any of my previous professors have had like a good way to remember that, but it's the exact opposite of our osteoblasts. Osteoclasts are breaking down the bone that has been made previously. So they're like they're tearing it down what the osteoblasts have made.
Right. So sometimes we tell our students osteoclast are the chompers. They're like little Pac-Men that are degrading the bony matrix. Maybe that helps.
I like that.
Okay, any other questions for Hailey? Okay. As with Kyle, Hailey did an excellent job. Thank you so much.
I think we have one more question.
Do we? Oh yes, Juan.
Sorry, could you
Good.
go back to the slide that describes osteoblast and explain where it originates from?
Yes. Hi. Okay.
Okay, yeah.
So
I got that.
osteoblast, where they originate from?
I just wanted to see the location.
Oh, okay. Okay.
Yeah, thank you.
So yes, they are located underneath our periosteum and endosteum. It's set on this slide.
Okay. All right, and with that, we will move on. Thank you, Hailey.
Thank you very much. I appreciate all of
And
your time and attention.
thank you. Excellent work. So transitioning into our last session in embryology. I would like to introduce Lily Zhang from the Sidney Kimmel Medical College at Thomas Jefferson University. Lily is from Queens, New York, and graduated from Princeton University with a BA in Spanish. She is currently a second-year medical student at the Sidney Kimmel Medical College with an interest in pediatrics. In her free time, Lily enjoys playing badminton, cooking and baking, and gardening.
Thank you so much for the introduction. Hi, everyone. My name
Thank
is
you,
Lily.
Lily.
I'm just going to start sharing my screen on my iPad for my presentation. Okay. That show up okay? All good. Nice. Thank you. Right. So I will be talking about embryology, specifically about gastrulation. For people who are viewing this on a minimized screen, I highly recommend expanding it to full screen just because the iPad dimensions are a little finicky on the screen. And we'll just hop right into it. So for today, our goals will be to define what is gastrulation, why is it important, and we're going to identify and label the 3 germ layers. Those are called the ectoderm, endoderm, and mesoderm on a diagram. And then we're going to go over why those 3 layers exist in the role of forming our bodies and our tissues and organs. So before I begin and dive into the nitty-gritty details, I do want to preface us with a summary of suffixes and terms that you're going to hear during this presentation, just because I know personally nomenclature gets very confusing for me. So for suffixes, you've probably heard the cyst versus blast, and then you're going to run into sites going forward. So for cyst, we learned about blastocyst last time. So cyst will be referring to kind of a tissue pouch. And overall, in terms of gastrulation right now, when we say the blastocyst, we're referring to our current embryo in its current stage of formation. With blast as a suffix, we're talking about immature cells. Hailey went over this as well. And then with cytes, we're looking at the mature cell. So that cell will be done differentiating and knows exactly what its purpose in life is, and it's ready to go do whatever function it's going to do. You're also going to hear about the endometrium today. Not really kind of in depth of what it does, but you're just going to hear me mention it in terms of in relation to the gastrulation process. And the endometrium, just to clarify, is a layer of muscle within an organ called the uterus. And the uterus is just the organ in which this fetus is currently growing. You're also going to hear about two sacs when I talk about the overall how the embryo is currently looking at gastrulation, the yolk sac versus the amniotic sac. Some of you probably have heard about amniotic fluid. So the amniotic sac is going to contain that fluid, but there is a key distinction between the yolk sac and the amniotic sac, which are going to be coexisting at a certain point during gastrulation. And the yolk sac specifically will be something that's temporary. It'll provide nutrition to the fetus, but temporarily it forms in around week 2, which is where we're currently at, and gets absorbed by that fetus after week 12. So by week 12, we don't see the yolk sac anymore. In contrast, the amniotic sac is also a fluid-filled sac. That's going to surround the fetus, and it forms around day 10 to 12 and remains until right before birth. And that sac, not only does it give nutrition to the fetus, but it also provides protection overall and thermoregulation. Dr. Peterson, did you want to?
Lily, if you don't mind, can I just jump in just for a
Mhm,
second?
yeah.
So this is on the recording. So I just wanted to point out to everyone that endometrium, we used kind of endosteum just a few minutes ago. So within, so this is the innermost lining of the uterus, which is where we had talked about last time about implantation. So the endometrium is not going to be a muscular layer. It's more like an epithelial layer. And I know Lily knows that. I just wanted that to be on the recording. And then the second thing I just wanted to make sure that everybody understood is that in other animal species, except for humans and some primates, the yolk sac is really important as a nutritional source, but in humans, it's really not. The yolk sac is, as Hailey described it here, it is going to become over time much, much smaller and become almost inconsequential. But early on, it is going to be the site where for the early embryo, blood cells are going to be produced. And so that's going to be really important as we move past gastrulation and we talk about the embryo developing a little embryonic heart in week 3. It doesn't do any good for the embryo to have a heart if it doesn't have anything to pump around inside of it. So it needs a structure that can make blood cells, and that's what the yolk sac does. So, okay, let's move on because this is exciting. It's really cool stuff.
Yeah, thank you so much. And yes, correction, endometrium will not be muscular, it'll be more epithelial. My handwriting is like chicken scratch, I'm sorry. Okay, so picking up where we left off, last time we had created, well, we haven't created, but last time we had formed a blastocyst, and we had gone over that there are 2 cell populations within our blastocyst, the inner versus the outer. The inner is what we're focusing on because it becomes the fetus, but the outer is also just as important because it becomes the placenta. And it ties into what Dr. Peterson was mentioning, how the yolk sac is early nutrition, very important, but then the placenta will do wonders in helping with the maternal nutrition of the fetus. At week 2, we had lost totipotency, unfortunately. So as a reminder, that's when the cell has the potential to become anything. And now we're multipotent. So options are a little more limited, but we're still able to differentiate into many different things. Our stem cells are now differentiating and specializing into different types of cells. We also discussed implantation, which will occur around 4 to 6 days after fertilization of the egg. And today we're going to discuss how that inner cell mass will form our 3 primary germ layers. That's going to make up all the tissues in our body. So super important. In terms of terminology, that inner cell mass, if you recall, was called the embryoblast, and the outer cell mass was called the trophoblast. Again, our suffix is blast, so we're not done yet. We're still differentiating. And there's also between those two areas, those two cell masses, we have a cavity, just a space. And that blastocyst cavity is going to be where our yolk sac is going to be formed, just in terms of orienting where we are in the structure itself. So I have learned in anatomy class that week 2 is called the week 2 of 2s, because everything is differentiating into pairs of things. So that embryoblast, which is going to be what we're looking at in making and forming the fetus, it differentiates into 2 layers, the epiblast and the hypoblast. Our star player here will be the epiblast, because the epiblast specifically is the thing that forms our embryo, and our hypoblast will be forming the lining of our beginning yolk sac. And we can't forget that we do have a trophoblast, that outer layer encasing all of this, and that's going to also form 2 layers, the inner layer called the cytotrophoblast and the outer layer called the syncytial trophoblast. Big mouthful, but essentially the syncytial trophoblast, it's going to be your docking zone. It's going to allows the fetus to implant into that layer of endometrium and kind of keep it steady as the fetus grows. And then on this diagram here, you're probably seeing like, oh my God, there's so many terminologies. We've got, this blastocyst cavity. We've got this thing about an amniotic cavity. I like to think of it as more at this point, we have the 2 layers, right? So at this point, it's called the bilaminar disc. And another way I like to think of it in terms of visualizing is overall we have, oh, that's an incomplete circle. But overall, we have that overall embryo. And within this, we have our bilaminar disc. Oh. So I'm just going to try to make it in different colors. So we've got 1 layer, which I said before, we had our epiblast, which is going to form our embryo. We had another layer, our hypoblast, which is going to form the lining of our yolk sac. And in terms of different the structure itself, there are currently with this bilaminar disc, there are now 2 spaces, right? We see that top space and the bottom space. And those spaces, also known as cavities, are different in their names. Because up here, if we said, right, if the hypoblast is going to line the yolk sac, then this cavity will be forming the yolk sac. And on the other side, the epiblast, behind that cavity is actually going to be called the amniotic cavity, which will then later, we'll end up developing an amniotic sac. So I just wanted to clarify, where are those sacs appearing from? They're all within that blastocyst space, getting ready to be formed based on the division of space within the blastocyst itself. Okay. Okay. Did I skip? Here we go. So I just want to highlight a quote that my anatomy professor highlighted in our lecture, just to really hit home, gastrulation is super important, guys. And the quote is by development biologist Lewis Wolpert, who said, "It is not birth, marriage, or death, but gastrulation, which is truly the most important time in your life, because it's going to dictate the formation of you, essentially." So what exactly is gastrulation? I really hyped it up. We're all getting to it. What exactly is it? In very general, broad terms, it's the development of our 2-layer bilaminar disc into a 3-layer trilaminar disc. And this is important because in gastrulation, not only are we growing, but we're also starting to establish our body axes. And the body axes are going to help, in anatomy, help you kind of structure, organize, that didn't sound correct English, sorry, organize our structures into different compartments, different kind of areas of the body. So the 3 axes here, this is going to be new terminology for most. Cranial versus caudal. I like to think of it as your head versus your tailbone. Ventral and dorsal, also known as anterior and posterior. So that will be ventral and anterior would be towards your chest. Dorsal, posterior is towards your back. And then left and right, we are left and rights. You're going to learn more about the establishment of these axes in the regional LOs, but I do just want to preface these terminologies because I'm going to reference specific aspects like dorsal. I'm going to reference the dorsal side, the cranial side, just to get you guys up to speed. So what goes on in gastrulation? Epiblast does everything. So the epiblast gives rise to all 3 primary germ layers. And you're probably wondering, like, what about the hypoblast, right? You said there was a hypoblast. The hypoblast gets impacted during the gastrulation process. And I actually am a big visual learner, so I prefer kind of like drawing out what happens. So hopefully this drawing makes sense. But at this point, we start off gastrulation with our bilaminar disc, our 2-layer disc. And the disc is kind of oval-shaped. So kind of just imagine if you took Play-Doh and just made 2 discs and put them on top of each other. And the reason why I want to choose the imagery of Play-Doh, what is a germ layer? So germ layer just means a layer of germ cells. Germ cells means it's a cell, like a precursor cell. It's going to form, it's going to differentiate and specialize into other types of cells that do more specific functions. So it's kind of like the elementary school version of a cell before they go off to college and choose majors and things like that. So that's a germ layer. Hopefully that helps, Campbell. So back to our bilaminar disc. Remember our axes, right? Caudal versus cranial. So it's kind of hard to look at this disc that looks like a coin and go, oh yes, there's a little fetus there, just because there's no outward structures have been created yet. But we're just gonna look at the disc and we're gonna call one end our caudal end, where the tailbone would be, and one end the cranial end, where the head of the fetus would be. And what happens in gastrulation is on that side, the side of the epiblast, which will then be called the dorsal side, which again would be the back of the baby, you get what's called a primitive streak starts to form. So essentially an indent occurs on that epiblast layer. And remember how I said think about 2 layers of Play-Doh? Imagine if an invisible pencil went on that top layer and just slightly scratched along the epiblast, that top layer, right? You'll see a small canal, a small indent formed as that pencil travels. So I want you to think of that line of the pencil as the primitive streak. And I want you to think of where that tip of the pencil would be as the primitive node. What do all of those things do? Well, to first preface, people who've learned embryology before, you might have heard primitive pit versus node, primitive streak versus groove. For our purposes, we're going to use the node to refer to both the pit and the node for now, and the streak to refer to both the streak and the groove, because location-wise, they're in the same place. They're just one evolves into the other in terms of, it's more of a nomenclature thing rather than a function thing. And so with that line, that indent being formed, our top epiblast layer on the dorsal side, at the end of that line, we're drawing that line from caudal to cranial. We're drawing that line from tailbone to the head. At the end of that line is that node, that primitive node where our invisible pencil tip would be. That node is sending a lot of chemical signals to the rest of the epiblast saying, hey, epiblast, I need you to do 3 things. I need you to 1, proliferate, so create more. I need you to 2, transform, because it's going to transition from epiblast to something called mesenchymal, which you don't have to get into the specifics of, but essentially the lateral parts, the side parts of the epiblast are going to get recruited to make more and then move. Move where? Move towards that midline, towards that primitive streak. And they're not only going to move towards the midline, they're also going to go down into that streak, because that streak is a canal, right? And we love gravity. So that thing's going to go towards the midline and move down into that primitive streak and through it. What happens when you go through that primitive streak? You start puncturing off into that layer underneath, to the hypoblast layer. So when that primitive streak and that primitive node are working together to make the epiblast layer make more cells and recruit them towards the middle, and that those cells come to the middle and go down and enter in between the epiblast and the hypoblast. Those first initial cells, when they come down and they start differentiating, they kind of invade into that hypoblast layer. So they start displacing the hypoblast. They're like, please make room. I need to make a line here. And so those cells come down, they displace that hypoblast off, and they create their own layer, causing you to form an endoderm. Then this node doesn't stop. It's still working. It's still recruiting, chemically signaling everything. Like, come on, come all, everyone come to my primitive streak. So more cells come in, the endoderm layer gets finalized, and then more cells come in and they're differentiating to form your second layer in the middle, because now you've opened the space between your epiblast and what used to be a hypoblast. And that cell layer becomes your mesoderm over here. And finally, because we already have a nice, already nicely set up cell layer on top called the epiblast, to finalize it off, because the epiblast, blast implies we're not done yet. With this gastrulation being done, the epiblast transforms into your ectoderm layer. And so that's what's going to form your 3 layers, your ectoderm in the most dorso, your mesoderm in between, and your endoderm, where your hypoblast would have been originally when you had a bilaminar disc. Hopefully that makes sense. And feel free to ask questions if it doesn't. So that was a lot of information, right? So let's do a learning checkpoint here. If we could open a poll, please, thank you. Which of these gives rise to the 3 primary germ layers? So cytotrophoblast versus syncytial trophoblast versus your epiblast versus your hypoblast versus different combinations of 2 answers there. I think everyone's pretty much done answering. All right, I'm going to end the poll in 3, 2, 1. All right, so half of you said C, some of y'all said A, a little smattering of E and F. So in this case, there's 1 star player in a gastrulation forming the 3 primary germ layers, and that is just the epiblast. So if you recall, cytotrophoblast refers to the inner layer of that outer section. So it's the part of the blastocyte that is not involved in making your fetus. The syncytial trophoblast is that outer layer of the outer layer of the outer portion that docks your fetus into the endometrium. So that's not going to help make any germ layers. Epiblast does the job, hypoblast gets pushed away. So hypoblast gets shuffled off to do the yolk sac lining instead. And then E and F are both wrong just because there's one thing and it's just the epiblast making all 3 germ layers. So we've made our 3 layers, finally. After lots of recruitment in that primitive streak with the primitive node, what does each layer form, right? How do we get from 3 little disc layers to a full body? And the way I like to think of it is I follow the prefix of the layer itself. I'm pretty sure whoever named the endo, meso, ectoderm just meant in terms of the order in which they appear on the disc, but coincidentally, what they form also kind of lines up with the prefixes. So if you think about the word endoderm, endo being innermost, think about what's innermost in your body, right? My organs would be one thing that I think of, and any inner linings. Specifically in this case, endoderm becomes the inner lining of your digestive system. So I do want to preface that it's not the digestive system itself, it's the inner lining of it. And I'll go into it in more detail later. But endo is inner, so I'm going to be making inner linings. My liver and pancreas are organs that are within me, pretty deep inside me. And then the lungs, specifically the inner layers of the lungs will be formed by the endoderm. So key thing, endoderm, inner, whatever is most inside, you would be thinking. Mesoderm, meso means middle. And I would think, okay, what's between my skin and my organs? What else is in the middle ground there? So one thing, like blood runs through my body, right? So mesoderm forms your circulatory system. I've got muscles, I've got bones, I've got a skeleton within me, right? So the skeletal system and the muscular system will be formed by the mesoderm. And I do have a nice functioning set of lungs that still needs to be created because my endoderm only made the inner layers of it. I still need the rest of the lung. That's going to be created by the mesoderm. The ectoderm, think outer, ectoderm outside, right? What's outside that you can see on me? My hair, my nails when I raise my hand, my skin. And you might be wondering, how does nervous system have to do with outside? Well, think about your nervous system helps you control your movements, right? So someone can see you move. So think ectoderm will also include your nervous system because actions are outward. But let's actually dive into each layer just because they do a lot of differentiation goes on. And within the layers themselves, there's a lot of differentiation there too. So let's start with innermost, endoderm. And this diagram on the right here, I think does a really good job of highlighting the organs and tissues involved in endoderm differentiation. So we start towards, the head region. The endoderm will give rise to the tissues of the thymus and the tonsils. So the thymus will be more towards your neck thorax, chest area. And tonsils in the back of your mouth there, they are going to regulate your immune system. So if I have a problem with my endoderm, my immune system will not have a fun time being formed. I'm also going to use, the endoderm is also going to form the parenchyma, pronunciation's hard, sorry, also known as functional tissue. So you learned at Hailey kind of connective tissue, lots of tissue that helps create structure in the body. Functional tissue would be tissue and cells that do something like secrete hormones, store things, they have a purpose other than just let's create the structure of the body. So the functional tissue of the parathyroid and thyroid glands will also be given rows to by the endoderm. And that's going to be in your neck region. And that's going to give you the ability to secrete a bunch of hormones that can regulate, a lot of functions in your body. And then inner linings, think inner linings. So inner lining of the respiratory tract, specifically, you're thinking of your trachea and lungs, right? Trachea is within your throat, branches down to your lungs. You're thinking of the inner lining of the GI tract, gastrointestinal tract, and that's going to include your esophagus, so the food tube that comes down when you swallow, goes into your stomach, follows through to your small intestine, your large intestine, and out into the rectum and out through your anus. And it's also going to create the ducts and functional tissues of the liver and pancreas specifically. So those are like key organs to remember for endoderm. And just to finish things off, moving from top to bottom, you're also going to create the inner lining of your bladder and urethra. So bladder, the organ that stores urine that you make, and urethra, the tube that lets you excrete your urine. Mesoderm, the middle thing. Mesoderm is kind of interesting because it is split up by something called a notochord that I'll go into and how it's being made. The mesoderm is split into 3 types: paraxial, intermediate, lateral plate. Each type differentiates into something different, but the way you would know which one is where in terms of organization is just in relation to the notochord, how close is it to the notochord? So your closest, paraxial, then intermediate, then lateral being sides, right? So paraxial will form part of your skull and the rest of your skeletal system. So your vertebrae, the spine bones, your ribs, which protect your lungs and heart. Your blood vessels will also be formed by the mesoderm, and the skeletal muscles that we talked about specifically on the back, your chest, your stomach, and your limbs are all going to be formed by the paraxial mesoderm. And the paraxial mesoderm will also form dermis of the body. Now, dermis, you might think dermatology, skin. Dermis is specifically a middle layer in the layers of your skin. So remember ectoderm, right? We want to think about the outside. Ectoderm is what's going to create the outside layer of the skin. Mesoderm is going to create the middle layer of the skin. Intermediate mesoderm specifically will give rise to your urogenital system. So that's just going to make anything that helps you make urine, your kidneys, the ureters, that there are tubes that come out of the kidney into your bladder, adrenal cortexes, which are these little glands on top that sit on top of your kidneys, and your gonads and ducts. So everything in your reproductive organ systems will be the intermediate mesoderm. And then finally, the lateral plate mesoderm also is within the lateral plate is split into 2. This split, again, think to yourself, mesoderm, all your splits are just based on location. So the lateral plate split between somatic and splanchnic. Somatic is just the part of the mesoderm that's closer to the ectoderm, because the mesoderm is in the sandwich, middle of the sandwich, right? The splanchnic is the part that's closer to the endoderm. Somatic will be in charge of making specifically your sternum, that bone in the center of your chest. And it's going to make the bones and connective tissues of your limbs. And it's going to create the membranes of the body cavities. Now, why is it important that we know that there's membranes of the body cavities? Think about the body. The human body is essentially just this big empty space filled with many things. And so in order to let these things sit right in the body, you're going to have membranes that kind of hold everything together. And the membranes have to encase both, they have to line both the actual empty spaces in your body, as well as you need membranes to hold your organs in a nice orderly fashion in your body. So your somatic will create the membranes that line the cavities. Your splanchnic will create the membranes that cover your organs. And the splanchnic will also do a nice job of creating the actual walls of the gut tube. The endoderm was going to create the linings, the inner linings of that gut tube. The rest of the gut tube is made by the splanchnic mesoderm. And then it's also going to create your spleen and your heart, 2 very important organs. Finally, with the ectoderm, what's going on there? Ectoderm, again, I said was like everything you see outside, right? So other than the hair, nails, skin, you're also thinking to yourself nervous system. So central nervous system, that's the brain and the spinal cord. Peripheral nervous system is all the nerves coming off my spinal cord to the rest of my body. And think about senses, right? You can see my eyes, nose, ears. Your senses are, your sensory organs are made thanks to your ectoderm layer being formed. And you're also going to learn about neurocrest cells in neurulation, but I do just want to highlight that neurocrest cells come from your ectoderm. Your ectoderm germ cells are going to form neurocrest cells. Oh, Dr. Peterson? Oh, perfect. Thank you. So that's ectoderm. So learning checkpoint number 2. Which of these correctly matches the organ derivative with its germ layer? A CNS is central nervous system. Sorry, I'm too used to abbreviating things. GI, we're thinking gut tube. We'll give it like 5 more seconds. 5, 4, 3, 2, 1. Ooh, people are shuffling. All right, I'm going to end the poll. Lock in your answers. Great. So majority of you chose F. Very well done. I'm sorry, these questions are very evil because of the little combinations that I like to put. But let's go through each one just so, because there was a smattering of diversity answers, and I do want to make sure everyone knows what's going on with these answer choices. So with answer choice A, central nervous system and the ectoderm lets you form all your nerves in your body, so that's good. B, the gut tube lining and the ectoderm, gut tube lining inside, right? So inside, endo. So this should be the endoderm. So that would also cross out E. C, heart and endoderm. The heart, you want to think more towards middle, right? So endo, it's going to be the endo, it will be the mesoderm. And ribs and mesoderm, that is correct. Part of the skeletal system is mesoderm. So A and D are both correct here. And just to finish up, notochord, right? I slammed it in there. I said the notochord, divides up the parts of the mesoderm, and then I walked away. The notochord is formed when so we have our primitive streak that was going from caudal to cranial. And as it was forming, we were recruiting cells into it. Now that node and streak is going to regress. So we're going to go from cranial to caudal this time. As it regresses, the node is still active. It's still recruiting cells. Cells are still coming in through that node, which has a little pit in which cells enter. And as it enters, well, now I've formed my mesoderm already, right? There's no space in between these two layers. So what happens when you have circular layers of cells coming in? A stack of circles makes a cylinder. So the tube starts forming in this section, in the mesoderm section. And that tube is just going to be called your notochord. And notochord is important in neurulation just because it helps set up, the different differentiations and cell layer thickenings that occur. But that's for neurulation lecture. I don't want to confuse y'all. That should be all for me in terms of gastrulation. These are my references. Thank you for your time. And I'll try my best to answer any questions.
For the sake of time, Lily, I'll just go ahead and try to answer Maria's question, and then that would give students watching the presentation a chance maybe to put their questions into the chat. Does that sound like a plan?
Yeah, thank you.
So I'm going to kind of make this a little bit simpler and just say the following. If you think mesoderm, think that all muscle tissue, whether it's skeletal, whether it's smooth muscle, or whether it's our cardiac muscle, those are the 3 different types of muscle. All muscle is derived from the mesoderm. All of our blood vessels and all of our connective tissue derive from the mesoderm. So if we think about organs in our body, those organs are either a hollow tube like the GI tract, or a hollow organ like the stomach, etc. So all of those organs are typically going to have a lining, and then they have a muscular layer. And because these are internal organs, the muscle layer is going to be either smooth muscle, or in the case of the heart, it's going to be cardiac muscle. So the middlemost layer in gastrulation mesoderm is also the middlemost layer of organs, which is the muscular layer. All connective tissue is also derived from the mesoderm. So most of our organs need some kind of protection, a protective layer on the outside in the space or cavity where they exist. And that too will be derived from the mesoderm. So now this is the mind-blowing part of this. So in an embryo, it starts out with a very primitive little gut tube that it generates starting around late week 3, week 4. So that gut tube is going to become the adult digestive system. If you think about what you know about the relationship of the trachea compared to the esophagus, the trachea, the windpipe, sits right in front of the gut tube or the esophagus. And the reason why is this: your respiratory system buds off of that gut tube and then becomes the entire respiratory system. So the lining of the gut tube, which Lily already talked about, is endoderm. When it buds off and forms another set of tubes, that lining is also going to be the lining of the respiratory system. But all of our respiratory tubes, like our bronchi and our bronchioles, need that middlemost muscular layer, which is mesoderm. So hopefully, Maria, that's helping you start to put together what we call the architecture of organs: an innermost lining, a middlemost muscular layer, and then an outermost kind of connective tissue layer. If that makes sense, you know a lot more than even most medical students do. So you guys made great progress tonight. So you should be really proud of yourselves.
What's the name for the circle in the mesoderm? So I'm assuming you're referring to that notochord. This one? Yes. Yep, that's the notochord.
And just to be clear, this is a cross section, you all. So it's like taking one piece of bread out of a loaf of bread. But really, the notochord is exactly what its name suggests. It's literally a cylinder or a cord that runs the length of this embryo, or the trilaminar disc, at least at this point. Okay.
Yes, Yuan?
Yes.
What exactly is the primitive node?
So the primitive node is moving, but specifically in terms of describing its location, it is on the cranial end of the primitive streak. So that line's growing, and as it grows, it recruits cells. That node at the cranial end is moving with it.
Does it actually exist, or is it just a term to kind of?
It does. So the primitive node is actually a little ball of cells at the end of that streak, and those cells send out chemical signaling that's like, hey guys, make more cells, come here.
So is the primitive streak also lining of cells?
So that's the tricky part. The primitive streak just refers to that like indentation. So technically the streak is lined by cells because it's just an indent in the epiblast, but you're not making more cells in the streak, if that makes sense.
So
it's more the
the
passage.
node helps us to identify the streak. Is it like that?
Sort of. How about if I'll just jump in? The streak actually gives rise to a groove, Jawan, and I would think of the groove almost like a cleft, or using a sort of Disney-like I don't know, fantasy movies. It's more like a portal. So the primitive groove is a portal for those cells to move through and become the endoderm or become the mesoderm. Is that better?
Yeah, thank you so much.
Thank you. Any final questions? Thank you. Yes, embryo is very intimidating, but it is very fun once you get the hang of it.
I agree. Do not see any other questions, so I think you're off the hook, Lily, for this evening. Thank you so much. And for the directors, do we have any final words of wisdom before we sign off for the evening?
I just want to say thank you to all of our presenters tonight, Lily, Kyle, and Haley. You all did a tremendous job. And we're only in session 2, so it gets me excited to watch you all blossom and continue on with your presentations. The only thing that we had to add was that your next session, session 3, will be on Sunday, October 13th. Same time, 6 p.m. Eastern time. And we hope to see you all there. So thank you all for coming and joining us this evening.
And recruit a friend.
And recruit a friend. Tell your high school teacher and have them recruit all your other colleagues and peers.
All right, take care.